The modern quest for eternal youth. When healthcare meets venture capital, the pursuit of extended life has captivated humanity since ancient times, weaving through mythology, literature, and scientific inquiry like a golden thread connecting our past to our present. Today, this age-old dream has taken on a distinctly contemporary flavor, with technology entrepreneurs pouring millions into experimental treatments that blur the boundaries between medicine and enhancement. Take the example of Bryan Johnson, who at 46 years old invested $2 million in various interventions, including receiving blood plasma from his own teenage child. This represents just one instance of wealthy individuals exploring radical approaches to combat aging through hormone therapies, nutrient infusions, and pharmaceutical interventions typically reserved for treating disease. The modern longevity movement encompasses far more than isolated experiments by eccentric millionaires. It represents a fundamental shift in how we conceptualize aging itself, transforming it from an inevitable process to a problem requiring technological solutions. This transformation reflects broader cultural changes, particularly in Silicon Valley, where disruption has become gospel and death represents the ultimate inefficiency to be optimized away. The language employed by longevity enthusiasts reveals this mindset. They speak of hacking biology, debugging cellular processes, and upgrading human hardware as if our bodies were merely computers running outdated software. Historical accounts reveal this fascination spans millennia, though each era has interpreted the quest through its own cultural lens. Ancient Greek historian Herodotus documented stories of the Macrobians, a people supposedly blessed with extraordinary longevity thanks to special waters that kept their skin remarkably youthful. These accounts, written in the 5th century BCE, demonstrate how even ancient civilizations recognized the connection between environmental factors and lifespan, though they attributed these effects to magical rather than scientific causes. Alexander the Great himself reportedly sought mythical life-extending waters during his military campaigns, integrating this personal quest into his broader mission of world conquest. His early death at 32 suggests his search proved fruitless, yet the legend persisted, inspiring countless others to seek similar fountains of youth. During the medieval era, artists like Lucas Cranach depicted scenes of elderly individuals entering mystical pools and emerging transformed into their younger selves, capturing humanity's enduring fantasy of reversing time's effects. These artistic representations served not merely as entertainment but as expressions of deep cultural anxieties about mortality and the human condition. The Renaissance brought new sophistication to longevity pursuits, with alchemists seeking the philosopher's stone not only for its supposed ability to transmute base metals into gold but also for its purported life-extending properties. This period marked a transition from purely mystical approaches to proto-scientific methods, though the line between magic and early chemistry remained blurry. Paracelsus, the Swiss physician and alchemist, developed elaborate theories about achieving immortality through chemical means, laying groundwork for both modern pharmacology and contemporary biohacking movements. This contemporary incarnation of the longevity movement raises fundamental questions about the nature and purpose of medical practice. When healthy young adults seek testosterone optimization or continuous glucose monitoring without any medical indication, we must ask whether such interventions constitute legitimate healthcare. The proliferation of direct-to-consumer health testing companies has democratized access to biomarker data, enabling individuals to track everything from genetic predispositions to real-time metabolic states. Yet this explosion of information often lacks the contextual interpretation that trained medical professionals provide, leading to anxiety and potentially harmful self-treatment. Most physicians would hesitate to prescribe these services to patients without clinical need, and insurance systems certainly wouldn't cover such expenses. This creates a two-tiered system where those with disposable income can access a wide array of preventive and enhancement services while others struggle to obtain basic care. The ethical implications extend beyond simple resource allocation, touching on fundamental questions about medical purpose and professional obligations. A recent podcast featured a venture capitalist expressing frustration with what he perceived as medical paternalism, arguing that doctors treat patients dismissively by refusing unnecessary tests. This perspective, increasingly common among technology entrepreneurs accustomed to immediate access and customization, misunderstands a crucial reality. Our healthcare infrastructure wasn't designed to accommodate wellness optimization for healthy individuals. The system struggles to meet the needs of those with genuine illness, let alone those seeking enhancement. This disconnect reflects broader tensions between Silicon Valley's disruptive ethos and medicine's conservative, evidence-based approach. The cultural clash extends deeper than mere resource allocation. Medicine operates on principles of beneficence and non-maleficence, requiring practitioners to balance potential benefits against risks. Every medical intervention, including seemingly benign tests, carries possibilities for false positives, overdiagnosis, and psychological harm from incidental findings. Technology entrepreneurs, accustomed to rapid iteration and acceptable failure rates in product development, often struggle to appreciate why medical professionals resist applying similar approaches to human health. The numbers paint a stark picture of our healthcare system's current challenges. Medical education experts predict a deficit of up to 40,000 primary care providers within the next decade. This shortage reflects multiple factors: the aging of current physicians, increasing patient complexity, administrative burdens that drive early retirement, and medical students' preference for specialized fields offering better work-life balance and compensation. As our population grows older and sicker, diverting medical resources toward healthy individuals seeking optimization creates ethical dilemmas that extend far beyond individual doctor-patient relationships. Each physician who abandons general practice for a boutique longevity clinic leaves approximately 2,000 patients searching for new providers in an already strained system. These transitions rarely happen overnight. Instead, they represent gradual shifts as physicians become frustrated with insurance requirements, time pressures, and the emotional toll of managing complex chronic diseases with inadequate resources. The allure of longevity medicine lies not just in financial rewards but in the opportunity to practice medicine as many physicians imagined it: lengthy conversations with patients, comprehensive preventive care, and genuine partnerships in health optimization. This resource allocation problem becomes particularly acute when considering diagnostic services. While affluent clients at specialized clinics receive immediate access to advanced imaging, patients with serious conditions often wait months for the same procedures. A concrete example illustrates this disparity. A healthy executive seeking a baseline full-body MRI can schedule one within days at a private imaging center, paying several $1,000s out of pocket. Meanwhile, a construction worker with persistent back pain and neurological symptoms might wait 8 weeks for insurance-approved imaging, potentially allowing a treatable condition to progress. The financial dynamics driving this shift deserve careful scrutiny. Traditional primary care, with its rapid-fire appointments and complex patient needs, proves less appealing than hour-long consultations with wealthy clients focused on optimization. The mathematics are compelling. A traditional primary care physician might see 25 patients daily, generating modest revenue per visit after insurance adjustments and administrative costs. A longevity-focused practice might see 8 patients daily at significantly higher rates, with minimal insurance hassles and more satisfying patient interactions. Yet medical training relies heavily on public funding, with taxpayers contributing billions annually to graduate medical education. This public investment arguably creates obligations to serve broader community needs rather than exclusively catering to those who can afford premium services. The social contract implicit in publicly funded medical education suggests that physicians bear some responsibility to address societal health needs, not merely market demands. The longevity movement's scientific foundations merit examination beyond ethical considerations. Many interventions promoted by longevity enthusiasts rest on preliminary research, animal studies, or theoretical frameworks lacking robust human trials. Metformin, for instance, shows promise for life extension based on observational studies of diabetic patients, but large-scale trials in healthy populations remain incomplete. Similarly, NAD+ supplementation relies heavily on cellular and animal research, with human benefits remaining largely theoretical. This gap between scientific evidence and commercial promotion creates risks for consumers who may invest substantial resources in unproven interventions. The supplement industry's minimal regulation compounds these concerns, as products marketed for longevity often lack standardization, purity testing, or efficacy validation. Consumers navigating this landscape face a bewildering array of options, from relatively benign vitamin supplements to experimental compounds with unknown long-term effects. Nevertheless, the longevity movement contributes valuable perspectives to healthcare discourse. Preventing disease through early intervention makes both medical and economic sense. The traditional medical models focus on treating established disease, rather than maintaining health represents a genuine limitation that longevity medicine addresses. People should have freedom to pursue health improvements using their own resources, and the movement's emphasis on personal agency and optimization resonates with broader cultural trends toward self-improvement and quantified self-movements. The democratization of health information, while creating challenges, also empowers individuals to take greater control of their well-being. Wearable devices tracking sleep, activity, and physiological parameters provide unprecedented insights into daily health patterns. When properly interpreted and acted upon, this information can motivate beneficial lifestyle changes that no amount of medical advice might achieve. The longevity movement's emphasis on measurement and optimization has spurred innovation in consumer health technology, benefiting broader populations beyond wealthy early adopters. Moving forward requires several considerations for integrating longevity medicine with traditional healthcare systems. First, claims about longevity interventions need rigorous scientific validation and transparent communication about evidence quality. Professional organizations might develop standards for longevity practices, similar to existing guidelines for preventive care, ensuring consumers receive accurate information about potential benefits and risks. Second, we must distinguish between medical necessity and enhancement, ensuring public resources prioritize actual healthcare needs. This distinction, while sometimes clear, often exists on a spectrum. Hormone replacement therapy for documented deficiency represents medical treatment. Optimizing hormones in healthy individuals for performance enhancement occupies different ethical territory. Developing frameworks for these distinctions requires input from medical professionals, ethicists, policymakers, and public representatives. Third, physicians entering longevity practice might consider maintaining connections to underserved communities through volunteer work or research benefiting wider populations. Some longevity clinics already implement sliding scale fees or pro bono services, recognizing their social obligations while maintaining financially viable practices. These models suggest possibilities for bridging the gap between boutique medicine and public health needs. Addressing systemic issues that drive physicians from traditional practice proves equally important. Administrative burdens and time pressures push many talented clinicians toward more manageable practice models. Electronic health records, designed to improve care coordination and documentation, often become time-consuming obstacles to patient interaction. Insurance prior authorizations, intended to control costs, create frustrating delays and administrative overhead. Reforming these structural problems could help maintain accessible care while allowing space for innovation. Perhaps most importantly, we must remember that population-level factors typically exert greater influence on longevity than individual interventions. Environmental quality, neighborhood safety, food security, and social connections impact health outcomes more profoundly than most supplements or monitoring devices. The Blue Zones research, identifying regions with exceptional longevity, highlights how community structures, dietary patterns, and lifestyle factors create environments supporting long, healthy lives without sophisticated medical interventions. Social determinants of health account for an estimated 80% of health outcomes, dwarfing the impact of medical care. Yet longevity medicine, with its focus on individual optimization, often overlooks these broader factors. A comprehensive approach to extending healthy lifespan must address both individual and societal levels, recognizing that personal choices occur within structural contexts that enable or constrain health behaviors. The promise of extending healthy human life represents an exciting frontier, but realizing this potential requires thoughtful consideration of distribution and values. Will longevity medicine become another arena where socioeconomic status determines outcomes, or can we develop approaches that democratize these advances? History suggests that medical innovations often begin as privileges for the wealthy before becoming widely accessible. Antibiotics, vaccines, and surgical procedures followed this pattern, eventually benefiting broad populations. Whether longevity interventions will follow similar trajectories depends on policy choices, technological advances, and social priorities. The integration of artificial intelligence and machine learning into longevity research offers both promises and perils. These technologies can analyze vast datasets to identify patterns in aging and potential interventions, accelerating research that might otherwise take decades. However, They also risk encoding existing health disparities into algorithms, potentially exacerbating inequalities in access to longevity interventions. Ensuring equitable development and deployment of these technologies requires deliberate attention to inclusivity and justice. After millennia of searching, from Herodotus to modern Silicon Valley, humanity continues seeking the secret to extended youth. Perhaps Aristotle identified the true formula centuries ago through his emphasis on physical activity, dietary moderation, and meaningful relationships. These simple prescriptions may lack the appeal needed to attract venture funding, but their wisdom endures. Modern research consistently validates these ancient insights, demonstrating how exercise, nutrition, and social connections profoundly impact both lifespan and health span. The psychological dimensions of longevity pursuits deserve consideration. The fear of death and desire for continued existence represent fundamental human experiences, driving both scientific research and sometimes desperate measures. The longevity movement channels these anxieties into action, offering hope and agency in facing mortality. Yet excessive focus on life extension can paradoxically diminish quality of life, creating anxiety about aging and death that interferes with present moment experience and acceptance of natural life cycles. The challenge facing contemporary medicine involves balancing innovation with equity, individual choice with collective responsibility, and technological possibility with human values. As we navigate this new frontier, these considerations will determine whether longevity science enhances human flourishing broadly or merely extends existing disparities into our additional years of life. The conversation must include diverse voices, not just entrepreneurs and scientists, but also ethicists, community representatives, and those currently excluded from healthcare access. Ultimately, the longevity movement reflects humanity's perpetual struggle with mortality and meaning. While extending healthy lifespan represents a worthy goal, we must ensure that pursuit doesn't overshadow the equally important task of improving life quality for all people, regardless of their ability to pay for cutting-edge interventions. The true measure of our success will lie not in maximum lifespan achieved by a privileged few, but in how well we enable all people to live healthy, meaningful lives for whatever time they have. As we stand at this crossroads between traditional medicine and longevity enhancement, the choices we make will shape not just individual health outcomes but the fundamental character of our healthcare system and society. The question isn't whether to pursue longevity research, but how to do so in ways that honor both human potential and human dignity, scientific progress and social justice, individual freedom and collective well-being. In answering these questions thoughtfully, we might find that the fountain of youth lies not in any single intervention, but in creating societies that support human flourishing across the entire lifespan.